It's February vacation time and flu season, and interviewees are proving elusive. Never fear. You can stretch your muscles and your mind with another listen to our conversation with Garen Wintemute on discussing guns with patients. Before that, here's some real news with Amy Herman of Physicians First Watch.
Thanks, Joe. First, a study finds that just one dose of human papillomavirus vaccine is associated with a significant reduction in cervical disease, similar to the risk reduction seen with 2 or even 3 doses. The CDC currently recommends 2 doses for people vaccinated between ages 9 and 14, and 3 doses for those vaccinated later. Next, this week, the illness caused by novel coronavirus got a new name, COVID-19, and the death toll from the illness passed that of SARS. In China, cases seemed to slow down, but this was followed by a sharp increase, in part due to new diagnostic criteria in Hubei province. As of Thursday, China reported roughly 60,000 confirmed cases, including nearly 1,400 deaths. Elsewhere, the National Tuberculosis Controllers Association and the CDC issued new guidelines on treating latent TB. The bottom line? Shorter rifamycin-based regimens are preferred over a longer course isoniazid monotherapy. Evidence shows that the shorter regimens are as effective as isoniazid monotherapy, but they are less toxic and they have better completion rates. Next up, a meta-analysis finds that there's very little evidence that any migraine prevention medication is effective in children. This includes beta blockers and topiramate. An editorialist advises experts to rewrite their guidelines, and he advises clinicians to not use preventive meds regularly in children with migraine. And finally, it appears that sedentary teens may be more likely to develop depressive symptoms. In a study, a group of young people wore accelerometers to measure their activity levels at ages 12, 14, and 16. At age 18, they were assessed for depressive symptoms. Turns out they became more and more sedentary as they aged, and the more sedentary they were, the higher their depression scores were at age 18. And that's it for this week. Stick around for one of Joe's clinical conversations.
This week, Ali Raja, the editor of NEJM Journal Watch Emergency Medicine and executive vice chair of the Emergency Medicine Department at Massachusetts General Hospital, again joins me as co-host. There shouldn't be any controversy about the idea of discussing firearm safety with patients. If clinicians advise on smoking, eating and drinking habits, sexual behavior, seatbelt, sunblock, and the like, why wouldn't they want to discuss gun safety? Firearms, remember, were responsible for more deaths per capita in 2017 than were motor vehicles, according to the CDC's National Center for Health Statistics. Dr. Raja and I are speaking with Garen Wintemute, a researcher whose team has just measured Californians' openness to discussing firearms with their clinicians. Dr. Wintemute's report in the journal Health Affairs confirms patients' willingness to discuss firearm safety, but rather than spend time wading through numbers, we're going to ask him about the implications of his findings for you as clinicians. Dr. Wintemute is a professor of emergency medicine at the University of California at Davis, where he is the Baker Terrett Chair in Violence Prevention. Welcome to Clinical Conversations, Dr. Wintemute.
Thanks for having me.
As we said in the introduction, Dr. Wintemute, we're not here to pick through your tables and p-values. Could you tell us what, in sum, your principal findings were?
Sure. We found that about 2/3 of people in a statewide survey endorsed the idea that, in general, it's appropriate for doctors to talk with patients about firearms. A smaller percentage for gun owners. But when we then asked, so what about if the patient also has some risk factors? They're depressed, suicidal, they have a substance abuse problem, etc. Support for doctors talking to patients went up to between 80 and 90%, and the difference between gun owners and non-owners went away. So what I take from this is when it's appropriate, when there's a specific reason to ask, patients expect and endorse that they will get those questions from doctors, including when the patients are gun owners.
Why do you think, you mentioned in the introduction to your paper, Dr. Wintemute, that clinicians are not having these conversations very often. Why do you think that they're reluctant to do so?
Well, there are lots of reasons. So I practice emergency medicine too, and these reasons apply to me as to all of us. First off, there isn't enough time. Well, we can find time. But the other two big ones are, A, I don't know enough about the problem. Fine, we're physicians. Do your homework, as we did about HIV/AIDS and opioids and so forth. The other, though, is there's concern that patients will be angry, that patients will see the conversation as irrelevant. And the point of our findings, the overall point is that's simply not true. When it's relevant, patients, including gun owners, think this is entirely appropriate.
You mentioned this a couple of answers ago, and you just reiterated it. The when it's appropriate clause that you've used a couple of times. So obviously, not every patient needs to be approached about this, of course. And so can you tell our listeners what signs in particular would prompt such a discussion? When is it appropriate?
Sure. So I think there are two cases when it's appropriate sort of across the board. If I'm a pediatrician, my patients are developmentally at risk, all of them, just because of their age. But for those of us who see adults, the factors that we have in mind are a prior history of violence, a history of substance abuse, a history of severe mental illness, maybe even in the moment, depression and so forth. And the key point here is that many of these risk factors are themselves things that bring patients to doctors. As an ER doc, I might be seeing somebody because they've been injured in a fight and they're drunk. So here are a couple of risk factors as part of the chief complaint, if you will. And my approach in such a situation is to, in the history taking, establish the risk factors and then to say, there are some risk factors for violence here. And in that situation, I ask some follow-up questions, which include access to weapons such as firearms. So, are there any firearms at home? Do you have access? What I've done is established relevance to the patient of the questions about firearms. And that's, I do this. I'm not just talking about it. And that's what gets me a conversation that is relevant from the patient's point of view.
Well, if somebody is in your emergency department and they're just been in a fight or they've come in and they're strung out on something, how do you broach the subject with them? Do you say it as directly as you have just related to us?
Well, of course, we all vary our conversations to fit the circumstances. If the patient's really intoxicated, I don't have the conversation. I wait until they're more sober. But no, sometimes it is quite straightforward. And what I have learned, and I think the findings kind of bear this out, patients aren't put off by it. If I've established relevance from their point of view as well as mine, I often say, the cards are face up here. Here's my thinking. There are some risk factors present, so let's have a conversation guided by those risk factors. They're not taken by surprise because I've set it up. And it's almost never have I had a patient say, I won't answer that question, or this is none of your business. And to be quite honest, when I do get that response, I say, fine by me, as I would for something else. I don't push it. But that's a rare event. Most people are happy to talk about it. I happen to be knowledgeable about firearms, so I will bring that in. They don't think I'm an egghead out working out of my depth. But the conversations have been fruitful. As often as not, I'll get, there are firearms at home, and I'll say, well, let's talk about storage. And I'm knowledgeable about those things because I've done my homework. And the outcome might be, maybe somebody should babysit my guns for a while. And we have procedures in California to allow for that. Or it might be, I'll think about it, but that's fine with me. Just as with tobacco, I don't expect every person I talk with about smoking to say, perfect, I'm chucking my cigarettes, I'm an ex-smoker as of now. We have to be realistic about our expectations.
So, Dr. Wintemute, you mentioned a couple of times that your knowledge about firearms helps you begin these conversations and helps them be more accepted by your patients. But not all physicians are going to be able to express that level of knowledge, nor are they going to enter these conversations with the same skill and experience that you obviously have. So have you had colleagues tell you stories about firearms discussions that haven't gone well? And can you share one with us and perhaps lessons that colleague or you took away from that?
Yes. So first off, I grew up around firearms and shot a bunch when I was younger. But like most of the people who are listening to this podcast, I had to study up when I decided to make this a part of my practice. And I should mention, we've published already a series of articles that provide the background information, and we can talk about where those articles are available at some point. But yes, I think it's not a personal anecdote, but one that I'm familiar with. A pediatrician in Florida asked the mother of one of his patients about firearms in the home, and the mother declined to answer. Fine. But what the pediatrician did was discharge the child and the child's two siblings from his practice.
Oh.
So that didn't go well. That actually led to legislation in Florida that set restrictions on doctors talking to patients about firearms. I think there's nothing more to this than common sense. If we're not knowledgeable about the topic, we need to do our homework, but we're used to that. We took an oath that in part says we will stay up to speed. I mean, that's an implication. So fine, we need to get up to speed about this. The other thing we need to do is have conversations, as we do on other things, that respect the patient's autonomy, that respect the likelihood that the patient's more knowledgeable about firearms than we are. But we proceed from a common ground, which is we want to ensure to the best that we can the patient's continued health and well-being.
I want to get back to I know we said we weren't going to discuss the data, but I want to get back to it for a minute. Were there any findings in this research that surprised you, Dr. Wintemute?
So surprised and really pleased me. When we looked at the crosstabs, I thought, this is the headline. The first question we asked was, in general, do you think it's appropriate for docs to talk to patients about firearms? And almost 40% of the firearm owners said, no, it's never appropriate in general. But when we added risk factors, the people who said it's never appropriate in general, by margins of 80 to 90% said, yes, of course it's appropriate when we added the risk factors in. And that flip, if you will, validated the clinical experience that we all had. There's a group of us as clinicians who do this work, and the research grew out of that. The key finding was, don't have this conversation when the patient won't think it's appropriate. They'll think you're an idiot. You're wasting your time and their time. Establish its appropriateness and then move ahead, and the patient will be there with you.
Yes,
even if the patient is a gun owner.
Speaking of that flipping, as I was reading through the article, I saw that there were some 40% of gun owners who said, no, don't ever, I don't want to talk about this stuff. But then then I was surprised myself when I saw that, 80% of them said under certain circumstances, yeah, it makes sense.
Yes.
So
that level of support didn't extend only to asking the question. We asked about interventions a clinician might take in a setting of suicidality. And we had that same level of support, including among firearm owners. And again, the common sense, when it's obviously the right thing to do, everybody agrees that, yeah, go ahead and do it, taking some sort of intervention at a time of risk.
So since our listeners are practicing clinicians, I just want to ask a very practical question. So how do you enter and, just as importantly, exit these discussions? So what do you actually say to patients to bring this topic up?
Yes. So I will first establish that this is a situation in which, in my judgment and likely the patients, it's appropriate. So I will have asked, as I asked just about everybody, I'm an ER doc, about alcohol. And again, the complaint that brought them in may make it obvious that risk is appropriate, risk is present. But I will ask some questions about risk. And if the answers are yes, I will say out loud, so there are some risk factors for violence here. The word's close to this. And in such situations, I ask questions that help me figure out how likely it is that risk might in fact, be realized we might have an adverse event. I ask questions about weapons, among other things. I ask questions about firearms, among other things. Pause, beat. So, are there any firearms in or around your home? Or I might ask, do you have access to firearms? In doing things in that order, I have first off shared my decision making with the patient and offered the opportunity to participate in judging whether risk is appropriate. But I've made it clear that I have their interests at heart. I'm not just bullying my way into firearms. I'm doing it because we've established that it's appropriateness. And depending on the answer I get back, I will pursue or move on to another topic.
I want to ask you, what do you hope will happen with your findings now, Dr. Wintemute? Do you want clinicians to be reassured and thus less reluctant to start these conversations?
That's very much the case. I want docs to understand that if they think it's appropriate in a specific instance, the patient probably does too, and the patient is okay with them asking the question. So I want them to feel encouraged. I want them, as we all do because we're conscientious, to then go out and do some homework. And we've made it easier, and we're going to make it much easier in the very near future to do that homework so that they feel competent to have the conversation. And I want them to do the homework that extends to knowing what the resources are that are available to them locally, particularly if there's an emergency. We have suicidality in the room, and guns are part of the equation, and we need to do something about it here and now.
I want to put a list of some of your publications of practical use to clinicians on the website. So if you will email those to me, I will post them.
Dr. Wintemute, you've done a lot of research in this area, and clearly we as clinicians should feel reassured to ask these questions. But what are you doing to make this easier for us?
Well, one of the things that we've been successful with in general with regard to firearm violence in California is getting support from the state for research and related efforts. So we have just received several $1 million from the state of California to design curricula, not just for physicians, but for health professionals across the board, nurses, paramedics, etc., for clinicians in practice and for health professionals in training. So we're in the process of designing those curricula. Some of the content will be specific to California, but most of it will be entirely appropriate for clinicians everywhere. We're going to implement that. We're going to put all of this up on the web, make it available to institutions in other states who want to grab what's relevant and then add in their own state-specific content. We're going to have what amounts to a speakers bureau going all around California facilitating this training, and across all of this, establishing a model that other states can pick up and use as they see fit.
I want to thank you, Dr. Wintemute, for talking with us today about your paper in Health Affairs.
Sure.
That was our 241st episode. The whole collection is searchable and available free at podcasts.jwatch.org. Clinical Conversations is a production of the NEJM Group, and we come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia.
And I'm Ollie Raja. Thanks for listening.